Okay, welcome all to Bridging the Oxygen Gap, building the missing middle between supply and care with the Oxygen CoLab. I'm Leith Greenslade, coordinator of the Every Breath Counts Coalition, and your moderator today. This is a very important conversation, not just about access to medical oxygen, but about access to health products more generally in low resource settings. For the past 5 years, the Oxygen CoLab has been pioneering new products, new models of service delivery, and new solutions to access barriers. And today you're going to hear from a number of experts in their growing network about all that they have learned, and most importantly, the implications it has for us in the way we all work in this new era of global health. So you'll have a lot of opportunity today to interact with these experts through Q&A. So we encourage you throughout to be posting comments and questions in the chat, and we'll be able to pick those up when we get to Q&A. Please keep your cameras and microphones off unless you're speaking, and we ask our speakers to do that as well. So we're going to do two sessions where you'll hear two different aspects of the CoLab's work. In the first session, you'll hear from the director, Alex Loznianu, and then you'll hear from three experts on oxygen as a service. Dr. Aisha Adeniji from Healthport, Nigeria, Dr. Karina King from Karolinska Institute, and well known to all of us as one of the lead authors on the Lancet Global Health Commission on Oxygen, and Dedrix Bindiba from Frio2, Uganda. So without further ado, let's kick off this important discussion, and I'm very delighted to hand over to Alex, Director of the CoLab.
Thank you very much, Leith, for the kind words and for the steady support you've provided us. We're going to cover a lot of work, a lot of ground today, as Leith said. So if there's one thing I'd love you all to take away, is this. As a global oxygen community, we achieved something remarkable with the production investments of the last decade. The infrastructure is now largely on the ground. And now we also have the evidence that local respiratory care businesses can connect that production to patients. When you invest in them, when you give them the right conditions. We see that as the next frontier. But that's not all. The timing of today's conversation really matters, as Leith also rightly pointed out. Everyone in global health is talking about the shift from aid to investment. And oftentimes I think it's quite hard to point to what that actually looks like in practice. We think medical oxygen shows you. It shows you what happens when you back local businesses. It shows you what happens when governments buy outcomes instead of equipment. It shows you what happens when you invest in the ecosystem and not just the infrastructure. And we really hope that what we're going to share with you all today is going to be useful to everyone in this room working on that transition from aid to investment. 5 years ago, the world didn't look like it does today. 5 years ago, the oxygen production infrastructure was only starting to ramp up. Today, thanks to an enormous collective effort, there are more than 100 PSA plants in Nigeria alone. And thanks to technology partnerships like Drive Developers and Sunrise, there's also a fit-for-purpose concentrator for the first time in the market. 5 years ago, we also had an inkling that perhaps engaging local private sector businesses to connect the production to last mile access and in facilities could be transformative. And today you'll hear lessons from entrepreneurs in the room like Healthport, Frio2, Afia, CPHD and Sunrise, who will show you how demand increased up to 2 to 3 times once reliable SMEs were in charge, and how uptime went to 100% despite 215 power outages. And I recognize that in the sector, sometimes we say these numbers and we sometimes say this often that they might lose their alarm, but think about the significance of having 100% uptime despite 215 power outages. 5 years ago, we also didn't have rigorous evidence that services-based models actually improve access to oxygen. When we started, there was a clear literature gap in this space. And today, we've proven it. And it's not just us saying it, it's world-leading experts from Karolinska Institute, Macquarie University, Melbourne University. And we're excited that today they'll be able to share the 2 new academic papers covering exactly that. 5 years ago, the world of aid looked different and commercial models were on the fringes. Today, we don't have that luxury, but we do have the opportunity and now the evidence to really bring commercial models to the main stage. And we have government champions from Nigeria and Uganda in the room with us today who are already building these conditions for the commercial markets to actually thrive in their markets. The lessons you'll hear today are the collective effort of an incredible group of people. And I really hope you'll find them as fascinating and inspiring as I do. Our Oxygen as a Service entrepreneurs, they really took the risk when the model was still unproven. Our research partners who brought the rigor, our friends from UNICEF, Oxygen Alliance, Oxygen Hub, they all rallied behind this collective effort. Of course, ministries of health in Nigeria, Uganda, Kenya, who are ready, and you will hear today, they're already pioneering new approaches. Our funder, FCDO, who have backed this work with extraordinary commitment since day one, and did something that's not to be taken for granted, and frankly quite rare. They really let the work evolve. So when the evidence pointed us from technology to services-based models to market conditions, they really followed the learning. And yeah, I couldn't say thank you enough for this trust. And thank you for all the skeptics, because of course you kept the work sharp. And I'm definitely running out of time to thank everyone, because so many of you made all of these transitions possible and really made these things happen that we never thought we'd see 5 years ago. So let me show you what came of it. We kept saying that we have so much data and so much information to share with you today. So before the data, let's look at the people. We spoke to Kimgiza John, a midwife at Kagadi Hospital in Uganda, who said, "We're no longer panicky or stressed when the power is off. We've actually just had a baby here for 3 weeks on oxygen. Without that constant oxygen availability given by the 302 LPOS backup system, we would have lost the baby." We also heard from Folashade Fadare from Harvey Road Hospital in Nigeria, who told us, "As a hospital manager, I have many issues every day. Since Healthport got here, oxygen is not one of them." And we also heard from engineer Francine Mutesi, Rwanda Food and Drugs Authority, who told us that the concentrator directory will now help us know which parameters to target when setting up guidelines and regulatory recommendations for these types of oxygen medical devices. So you can see a midwife who can now focus on her patient, a hospital manager who doesn't have the burden of oxygen anymore. She doesn't have to think about that anymore. A regulator who has the tools to really make the right decisions and set the right standards. And this is really what kept us going and what we've been working towards. So I'll briefly share with you how we got there. When we started, we've seen a range of actors and institutions who are working independently from one another on product innovation. So as a CoLab, being a CoLab, we brought together over 100 experts, really tried to understand what are the evidence gaps in order to inform UNICEF's target product profile, which was defining what a fit-for-purpose concentrator actually looks like. We moved into making catalytic R&D investments to manufacturers, and this really unlocked a wave of more funding, because once the risk within those manufacturers came down, they were also able to co-invest their own significant funds in R&D. This led, of course, to the Pulmo 2, the first concentrator on the market that meets the target product profile. And we noticed very soon that even having a fit-for-purpose device on the market, countries still purchased and funders still donated equipment that was not fit for purpose. So that's why we wanted to independently test the 11 most popular concentrator models against the UNICEF TPP, really giving decision makers this reliable data for the first time. It was also important for us to look broader and to invest in this, what we call supportive technology, that really makes delivery cheaper and more reliable. So we funded innovations for remote monitoring, backup storage, virtually assisted maintenance. And we won't have time to go through all of it, but we'll leave you with all of these global goods that came out from the product innovation side of our work, so you can look into it in your own time. But then as we worked, something became very clear. The businesses that were using these products had challenges that actually went well beyond the technology. So health facilities really told us they needed partners who can provide everything together, not just the equipment, but the maintenance, distribution, training, support. So that's what led us to adding this new area of our work and our focus on services-based models. And we also knew that if we really wanted anyone to take this seriously, we needed the rigorous evidence, and not just that it works, but what works, what doesn't work, why does it not work. So that's why we also focused on the evidence into action and brought an amazing group of partners across all of these areas that we got to do this with. So what are services-based models? You heard me talk about them. This is, you'll see here on this slide a bit of like our definition of it, but in the crux of it is that instead of buying equipment and carrying the ongoing burden of keeping it running, a health facility actually pays a recurring fee to a local provider who then takes this responsibility for the whole thing, for the equipment, for the maintenance, for the clinical training, for the backups. This means that the facility can focus on the patient care, the provider focuses on keeping the oxygen flowing. And you'll see on this slide on the right-hand side, our portfolio of oxygen as a service. We backed 5 businesses doing exactly this: Healthport in Nigeria, Frio2 in Uganda and in Tanzania, Sunray in India, CPHD in Kenya, and Afia in Uganda. But yes, rather than me telling you all about how it actually works, let's hear from the entrepreneurs actually building companies around these models. So I'll hand it over to you, Aisha Adeniji, CEO and co-founder of Healthport.
Thank you so very much, Alex. It's my pleasure to be here today, and thank you for the opportunity. It's been a privilege to be part of the CoLab team and cohort, and also it's been a privilege to be able to service a lot of the hospitals that in Nigeria and other partners as well. So Healthport really exists to solve problems that's been identified in literature and also in practice. All right. So when we talk about medical oxygen access, the conversation typically begins with the production side of things. You know, how many plants exist, how many cylinders are deployed or filled, or concentrators in their brands. But what we realize over the years working in Nigeria is that oxygen production is not a matter of a production only problem. It's a reliability problem. So in Nigeria, technically, as Alex has mentioned, oxygen technically exists, right? The plants operate in certain instances, the cylinders get to the hospital in some cases, but yet facilities that Healthport encounters, a lot of them still do not have a consistent medical oxygen available. So again, this is what we solve for at Healthport, and this is what we aim to do differently and consistently over the years to come. Our service model is designed to not only produce oxygen using on-site solar or near-site equipment in certain cases, but really to ensure that we co-create dependable systems that the hospitals and the clinicians that we work with have a resource that they can rely on when it comes to their patient care needs. We have, without a doubt, iterated along the way. And for everyone that's followed the Healthport story, you've seen how we changed swapped equipment, changed the model from concentrator only, again, just to manage the needs of these facilities that we service. So our service really follows a model where we are training, we're handling logistics, we're handling procurement cycles, we're being conscious and consistently keeping in mind what the revenue cycles look like for these hospitals. We do all of this, ensuring 100% uptime of oxygen over the 4 years that we've partnered with hospitals in Lagos, Ogun State, and in Kwara. And we have less than 5% churn rate, meaning that hospitals that have tasted the differentiated experience with Healthport prefers to stay with us and do business with us. And we are really appreciative of that opportunity to grow and to learn alongside them. There's a lot more that needs to be done, a lot more facilities to be covered. But to be able to do this, certain things would need to happen, as will be mentioned later on, right? So we do all of this without losing sight of what our unit economics look like and our cash flow, right? As a business, we want to ensure that we are in it for the long term. And that these hospitals that have grown to rely on the health support services don't have to backtrack if in a situation that we don't envisage health what no longer exists, right? So utilization we have seen across a facility is what determines sustainability. It also helps us from a business perspective to ensure that our plants are sized to fit the facility need. We have to keep, in terms of internal metrics, over 75% utilization rates for all our plants that are situated on site. We cluster our facilities intentionally to ensure that we maintain optimized routes for redistribution and ensure that reliability that has become our ethos over the years. So our processes. Next slide, please. So in all of this, basically, we have key learnings over time, and facilities do have their own individual peculiarities. The HealthPort model is replicable across many sites. However, it's not a cookie cutter model. We design really to fit the actual needs of the hospital. When we go into any facility, before we contract, we're looking at what's their patient volume, what kind of services do they provide, what kind of assets they already have on site, and how do we mitigate and for a synergistic outcome, right? So in terms of financing, we design to fit, again, facility need in terms of pricing and what's the most economically friendly approach to ensure that we're financially sustainable, but at the same time, this process is not too heavy for the hospital to lift. So we do our contracting that lasts over a longer period of time, and this is to help us de-risk. We also price lock for our hospital partners for a whole year so that when they're budgeting, they have an idea of what it would cost them for oxygen over time. We provide very integrated data to the hospital to show them this is how your utilization trend have changed or shifted over time. And again, this helps the hospital plan better and without a doubt also helps our operational processes. We are also able to reliably unlock latent demand. When what we've seen across all our sites is when clinicians know that oxygen would always be available, the way they approach their patient assessment, granted, we do very, very integrate training with our nurses and clinicians and biomeds on sites to ensure that everyone knows what to do when a patient comes in, that they have the tools such as the pulse oximeter and are using it consistently to identify and diagnose this patient in time. But there's something that shifts when clinicians know that the resource they need to treat patients is available, and that is a shift in utilization rate. So we've been able to, again, maintain uninterrupted supply across all our facilities. And with that, we've seen oxygen usage gradually grow, and we are designed to grow alongside this hospital. So we service hospitals in urban area, rural. It does not matter if a patient is presenting there, there's an oxygen need. And that's how we design this model. Clustering also is another lesson that has really helped us in terms of reliability and trust, right? Because we design our model to kind of be codependent. And in codependency means that we can use data to inform how we shift oxygen resource from one facility to the other. If one facility is experiencing an uptick, it's not the hospital administration's responsibility only to make that shift for what needs to happen, but HealthWort is readily on site, a very high human touch process to help them make that shift so that the clinicians at the bedside do not even feel what that change might look like. So network density helps our unit economics. It does help sustainability over time, and it does help gain the trust of these clinicians and hospitals that we work with. Next slide, please. So there's a lot of learning that has happened across different facilities and again, across different oxygen as a service operators in different countries. And we invite you to explore the guide and see how many more of the health ports we can create so that hospital systems in the areas where we service can access reliable medical oxygen. I'll pass it on to Dr. Karina. Thank you.
Thank you so much, Aisha. It's Miranda will pop the link in the chat. This is indeed a very useful resource for any business who'd like to provide oxygen services. It's tips from the CoLab entrepreneurs that have been very, very generous with their insights. So we're very excited to launch it today with you all. Take a look and let us know in the chat and in the Q&A. You've heard what this looks like from the entrepreneur's perspective. Now let's hear what the evidence says. So Dr. Karina King from Karolinska Institute and co-author Lancet Global Commission on Medical Oxygen Security has been leading the independent evaluation of these models. Karina.
Thank you so much. Yeah, as you said, we were a group of academics who were brought in to do an independent evaluation of how Oxygen as a Service was performing. So next slide. So this is the culmination of our research group's evaluation. And the first thing I'll just start with is we started by conceptualizing how these 5 pilots were similar, because all these service offerings are different. And Oxygen as a Service is a very broad term, which can apply to large scale production down to providing kind of much smaller scale service offerings. So the first thing you'll notice when I talk about Oxygen as a Service is we talk about outsourced oxygen to the bedside as a subset of service models that are focused on a bundle of reliable oxygen supply to the point of use. So really about that last mile delivery into the facility, provided by an external private entity, with the absolute minimum service delivery of a medical oxygen supply to the facility, including provisions to get it to the bedside, which often people forget about that part. If you have a cylinder delivered to a facility, that doesn't mean that you can easily get it to a patient bedside. So that consideration of also how to get it to the patient's bed, as well as responsibility for equipment management, maintenance, repairs, and then various add-ons to that. So examples of pulse oximetry and training as additional add-ons that are delivered through a bundled fee. And so Aisha presented one example of these Oxygen as a Service models that we would classify as being outsourced oxygen to the bedside. Next slide, please. So what did we find from this evaluation? Well, the first thing was, did they work? So the purpose of these O2B models is to try and improve patient access to oxygen. And what we found was, when comparing in facilities, and we assessed facilities across 5 countries, and we assessed this through facility audits in over 20 facilities across the 5 countries, interviewed 59 healthcare workers and facility providers, did surveys with healthcare workers. So we had about 200 surveys with healthcare workers to try and evaluate, and did audits on all the equipment. When you look at Oxygen as a Service provided equipment compared to the equipment that the facility had before, we see that the Oxygen as a Service equipment was far more functional. So 95% of concentrators provided through this service were functional, compared to just 25% of those that facilities had previously or from other sources. Cylinders, the same, were much more often considered functional. And the reason that cylinders were most often not considered functional was not that they were empty, but actually was the lack of regulators on them. So they were there, but they couldn't be used. And pulse oximeters were more present. The other thing was that their systems were much more appropriate in their setup. So we only saw things like flow splitters when they had been provided by the Oxygen as a Service provider. We only saw backup oxygen systems when they had been provided by the Oxygen as a Service provider. And we only saw age-appropriate pulse oximeters for neonates and children when they had been provided by the Oxygen as a Service provider. So it wasn't simply that the equipment was all more functional, it's that the system for oxygen provision to patients was more appropriate for the wards. Next slide, please. How did they work? So the main mechanism that we observed was not necessarily a higher volume of equipment on the wards, but that the equipment was easier to use. Healthcare workers felt comfortable. They also had training and orientation on using them, which meant that there was more appropriate use of the equipment. That led to better awareness around maintenance, and there were rapid repairs and maintenance that were done routinely, which meant that the equipment was better deployed. And that in turn improved staff confidence in the facility's ability to treat patients. And I think this really reflects what Aisha had already said. That had led to a positive impact on the workplace culture around oxygen. So we saw that the mechanism through which it worked was not more oxygen being needed, but it was better maintained and more appropriate equipment, led to healthcare workers being more confident in delivering oxygen, which led to a positive impact on the workplace environment and patients' trust in the healthcare system. So it was really this positive feedback loop in healthcare worker confidence in their facility. Next slide, please. But there were things that we noted that needed more work. In general, the training was somewhat inconsistent and not always understood between the different pilots, and didn't necessarily lead to increase in knowledge amongst healthcare workers around delivering oxygen. So the training was often requested. So rethinking maybe the value, but also how to approach training as part of this service provision is one area that needs a bit more thought. The other one that came out consistently across all the sites was a lack of clarity sometimes by healthcare workers and facility managers about what was actually included in the service package. And I think this means that there's opportunities for these services to be exploited more. So often healthcare workers weren't aware that maintenance was part of a package, and so didn't flag when things were broken because they didn't know that they could. And so there's potential here to make these services even more effective through better orientation of all staff that come into contact. And we had suggestions for oxygen champions come up in quite a few places, where if there's a point person that can manage that communication and orientation when there's frequent staff turnovers. We also had lots of requests in the evaluation for extra add-ons from everyone, which I think is already there. But those add-ons were most often infrastructural as well as training. So needing better power supplies came up. And so more kind of the infrastructure that not all the services had touched on. And the final is this difference between willingness to pay, and we really saw that come through strongly. People really appreciated the services and they could see that it had made a difference. And so we saw there was a willingness to pay quite often, but the ability to pay was not always there. And this varied a huge amount across the different health systems. And so needing to understand the power in the health system of who can make a decision to pay and who pays and where it comes from is really important in terms of how these oxygen as a service models can be scaled up or implemented in different health systems. Next slide, please. So in conclusion, I think from the evaluation we saw, these services can improve oxygen access consistently across contexts. The maintained appropriate setup of equipment was really, really critical. But some contexts need to be thought of a little bit more around payment, training, capacity, and whether the economies of scale hold across different health systems. Thank you so much.
Thank you, Karina. Such much weighted evidence and really great to see it shared today. And now from another angle, Dedrick Stevenson Bindiba from FRIO2, who's been delivering oxygen as a service across Uganda and Tanzania. Dedrick, tell us, what has FRIO2 learned?
Thank you so much for the opportunity to share how FRIO2 is strengthening local systems through reliable oxygen access. Looking at the innovation of FRIO2 that spans 151 remote health facilities that supports reliable oxygen systems. This means that facilities that previously struggled with about 151 of these remote facilities in Uganda, Kenya, Tanzania, and Solomon Islands that struggled with inconsistent oxygen supply now have oxygen that directly is provided at the point of care. As a result, next slide, about 20,000 children under 5 are receiving oxygen treatment every year in these supported facilities. This scale of treatment contributes to about 700 lives saved annually, and approximately 60,000 disability-adjusted life years are being averted on an annual basis. These numbers demonstrate how reliable oxygen systems translate directly into survival for these vulnerable children. But the impact goes beyond clinical outcomes. When oxygen is available locally, patients no longer need to be able to urgently be traveled to higher levels of referrals for oxygen therapy. And as a result, about 18,000 of them, about 18,000 of emergency referrals, what would have been emergency referrals, are being avoided. I should say that for families, this is extremely very important in the context of where these systems are operating. It means they avoid long, costly travels, critically ill patients receiving treatment much faster than they would have if these systems were not in these 151 facilities. In total, this has prevented more than 565 kilometers of referral travel, whereby each patient would require about 60 kilometers of travel to access oxygen treatment to the next facility where they would be referred. This is a major burden removed from families, ambulances, and district health systems, as where these systems are operating, the burden of this is or rests on all the points of the patient, the facility, and the district health system. There are also efficiency gains that we talk about when we look at this. By strengthening health systems at different facility levels, the program has helped save, or the innovation has helped to save more than 8,500 oxygen cylinders that would have had to reach those facilities where these patients are accessing oxygen treatment. And I should say that this reduces transport costs, supply pressures, and logistical challenges in the context of where these facilities are actually situated. Remote facilities, as I should say, that face most of the challenges that have to do with the supply chain. And looking at the economic value, these improvements also generate significant economic benefits for the health system, for the individual, for the health facility, and as this innovation within 1 year is able to result into 550,000 US dollars in health system strengthening. This is a cost that would have been met in terms of cylinder transportation, in terms of referrals at both the facility and at an individual level. For us, this demonstrates that investing in reliable oxygen systems is not only life-saving, but also cost-effective for the health system, but also for the individual, who most of the times suffers or meets the biggest cost that is involved in terms of referral. Perhaps the most important outcome that I should highlight in this is the sustainability. We, having been engaged with the ministries in where this innovation has been implemented in Uganda, Kenya, Tanzania, and Solomon Island, particularly for Uganda, where almost 70% of this innovation is being implemented, the government has now committed to taking on the operational cost of these systems, having realized how effective and how important these systems have been at lower level facilities or remote level facilities where big plants do not exist. And this shows that that innovation is not just a project, but is not just an intervention, but just a sustainability issue that has to be considered. And it is becoming part of the health system itself. And the ministries are demanding for more conversation about how to be able to integrate this innovation at lower facilities so as to increase the access, demand, and of oxygen support. And this is where local system strengthening and innovation intersect. We are observing this very vividly in the environments where we are implementing this. So I would say that FreeOT is not simply delivering oxygen equipment. It is demonstrating how oxygen systems can be reliable, affordable, and integrated in routine health services. And this is essential if we want oxygen access to be sustained beyond project funding, where most of innovations always find themselves seated. So we are requiring...
Dedrix, if you could wrap up shortly, please. We're over time. Thank you.
All right. So ultimately, every patient who needs oxygen should be able to access this oxygen. And our experience is that with the right systems and approach and partnerships, this goal is achievable. Thank you so much.
Brilliant. Thank you so much. So that ends our first session. And I want to thank our speakers, Alex, Aisha, Karina, and Dedrix. So you've heard examples of individual very important initiatives in Nigeria, Uganda, and Karina gave you an overview independent that these work. Now we're going to pivot to our second session, where we're going to be talking about the kind of environment or market environment that's required to make these individual initiatives thrive. So building resilient local oxygen markets. And I'm going to introduce, we're going to have 4 excellent speakers in this session. First of all, Jason Hodak from the Oxygen CoLab. He's also one of, I would say, the world's experts on how medical oxygen markets actually work in low resource settings. Jason's joined by Dr. Gilbert Shetak, who leads the National Oxygen Desk at the Federal Ministry of Health in Nigeria. Very, very important leader in oxygen. Sheila Bagayana from Oxygen CoLab in Uganda, and Rachel Mujwimana, who works for the Uganda National Drug Authority. But Jason, over to you to kick us off.
Thanks very much, Leith. We're going to move through a lot of content a little bit quickly, so I encourage folks, if something catches your eye, if you have a question, drop it in the chat. We'll try to get through it as we're going, or we'll come to the Q&A at the end. But we can go to the next slide. We've heard now a description and some of the evidence behind services-based models for oxygen delivery. I want to open this section by giving you all a snapshot of what the Uganda CoLab team heard when they spoke to health facilities, manufacturers, and distributors in Uganda. So most had no prior awareness of what a services-based model is, but when they explained the concept, the interest was pretty striking. Strong among all 3 groups: health facilities, manufacturers, and distributors. And this tells us something important about the potential latent demand and the structure of the value chain in a lot of medical oxygen markets in LMICs. If we go to the next slide, we think the reason that interest is so strong is that most people, if not everyone, who are operating in these value chains can actually feel the same problem. So over the last decade, there's been huge investments in oxygen production. PSA plants, deals with industrial gas producers, lots of oxygen concentrators coming on ground. That supply side story is real, and it's having a lot of important impact on the ground. But it's also exposing a weakness: the gap between having oxygen produced and having it at the patient bedside. So equipment breaks down with no maintenance. If consumables aren't available, oxygen can't be delivered to patients. If clinician training is missing, clinicians can't identify which patients need oxygen. So the real problem that we have in the value chain, in the delivery of medical oxygen, is everything that's missing in the middle. If we move to the next slide, we think that the solution to that problem lies in a layer of local healthcare SMEs that can actually bridge the gap between production on the supply side and patient delivery on the health facility or the demand side. So companies in that middle portion of the value chain can do 2 things that neither large industrial producers nor health facilities do well on their own. The first is that they can bundle everything a facility needs, the oxygen supply, the equipment, the maintenance, the consumables, the training, into a single service, as we've been hearing about in the first half of the webinar. The second is that they can aggregate demand from many small dispersed health facilities into a customer profile that actually works for the larger producers who are built around more geographically centralized and high volume customers, right? So building this layer of the value chain is what will actually allow us to translate production into patient access. To build that layer, if we go to the next slide, we need to work in 4 areas. Now, we get to kind of stand on the shoulders of giants here. None of this would be new to folks who've done market shaping work in global health, right? So firstly, we need to aggregate demand and streamline procurement. We also need regulatory frameworks that enable market entry and market development while protecting quality and patient safety at the same time. We need to be able to support the SMEs who occupy that middle of the value chain with capital, including blended finance, as well as technical and commercial planning support. And we need to unlock oxygen financing, not just by finding new money in these systems, but by also understanding what's already being spent on oxygen in the system, coordinating it and making sure it buys more and goes further. So together, these 4 areas of work can create the conditions for sustainable, locally serviced oxygen markets that bridge that gap between the production and supply base on the one hand and health facility need and patient care on the other hand. If we go to the next slide, oh, thank you. So we're going to be releasing a lot of resources across these areas, some supplier landscaping reports, regulatory frameworks, and foundational trainings for regulators. We have a brief on target services profiles for strengthening procurement processes, analyses of oxygen financing approaches from work in Kenya. We're going to share links to all of those subsequent to this webinar. But for now, if we move to the next slide, I want to bring us specifically to Nigeria. Over the last decade, Nigeria has installed over 100 PSA plants. It has significant LOX production capacity, well over 100 tons per day. And the CoLab's first pass mapping of the supplier landscape identified over 100 different verified medical oxygen suppliers who were sitting in that middle of the value chain position. And we're currently doing a second pass. We think that number is going to get closer to 200 by the end. Most of these companies are small. They're serving 6 to 10 facilities, but only about a third report being reliably profitable. And almost 2/3 can't access outside capital. So the picture that we have in Nigeria is there's real supply capacity. There is a growing ecosystem of companies that are trying to help bridge the gap between that production capacity and what health facilities need. We have a Ministry of Health that has been on the forefront of medical oxygen access since it was on the map well before COVID. And Nigeria is facing really a challenge of moving from an infrastructure investment era to a patient access and reliability era. And we're very fortunate to have Dr. Gilbert Shitak, who's the National Oxygen Desk Officer from Nigeria's Federal Ministry of Health, who has been working on oxygen since most people even knew it was an issue. He's here with us today. He's going to talk about what government is doing and what's needed to bridge that gap. So I'm going to pass it over now to Dr. Shitak to walk us through that.
Do we have Dr. Gilbert Shitak with us? or a representative from the federal ministry? I'm not seeing Dr.
Yeah.
Shatak.
Shatak is here.
Ah, we see you. You have another name, Dr. Shatak. Welcome. Over to you.
All right. Thank you, Jason.
You're on mute, Dr. Shatak.
Okay. Can you hear me now?
Yes, we can, very clearly.
Oh, okay. Thank you. The situation in Nigeria, of course, we started our journey in 2016, and through the COVID era, now we are almost saturated. Let me not say we are saturated, but we are almost saturated. We have oxygen plants over 120. We have 112 geopolitical senatorial districts in the country. And for now, each senatorial district actually has an oxygen plant, a PSA plant. We also have quite a number of LOX tanks in several hospitals, in about 25 hospitals in Nigeria now. And we have the LOX operators. The private sector operators are also there. So we are almost saturated with this number of oxygen system across the country. However, in each of these senatorial districts, you have about 6 to 10 local governments, and each of them has a general hospital. So you can see that the PSA plan in each geopolitical zone serves as hope and spoke for all the general hospitals in that axis. We have what we call United for Oxygen in Nigeria. That is everybody participating in oxygen space is working with us on oxygen. And so we have a lot of hands on deck from partners to private sectors and to government agencies and to universities. Now, having all these oxygen systems, what else do we do? Because it's not just having the system that matters. What we need now is how do we get this oxygen to the bedside? How do we get enough cylinders to deliver this oxygen? How do we get piping systems so that we can deliver oxygens from manifold? How do we get local representatives, small and medium scale industries that can also assist in distributing this oxygen to the last mile? That is presently what we're working on. But production, we're almost there. That's we have almost enough capacity for the country now to produce enough oxygen. But what we need now is how do we deliver them to the last mile, which is what we are working on with a lot of other partners. But it is important to note here that even if we require more oxygen production system, we would love to have a situation whereby it comes with a maintenance plan. In a situation where donor agencies send systems, but there are no maintenance plan, it doesn't help because the biomedical engineering capability is not very excellent yet. We're still working on it, and we're still trying to do that as much as possible. So what we are working on now is, of course, the Nigerian government is setting the rules to, of course, procure properly and reliably too, and also to distribute to the hospitals that require them. The private sectors, of course, they are there, but they may not be as many as we could require in Nigeria. We will need more of those private sectors who could also help in maintaining those oxygen systems and also work as distributors to distribute quality oxygen to the last mile. Partners have been working a lot with us. We have quite a number of partners, but well, I think today I will briefly talk about CoLab, who has been actually supporting in this identifying the small gaps. And sometimes I actually wonder how my friend Jason works in Nigeria. He is able to get access to some places that even me as a Nigerian have not been able to get, because we are trying to ensure that every other partners, every government agencies from NAFDAC to standard organization, that they will come hand in hand so that we can be able to get a good quality oxygen to the hospitals at primary healthcare, secondary healthcare, and tertiary healthcare. So supporting us from partners will also assist very much in this distribution system, because somehow that is a missing link. We have been able to ensure that every state included in what we call annual operation plan. Annual operation plan in Nigeria is a system whereby if you have that in your annual operation plan, we know that every year it is captured in your budget. The other situation we're having right now is budget releases. They either don't come or they don't come when actually needed. Those are the gaps that we will need the partners to be able to fill in while we're waiting for budget releases, or they can even support in preparing our budget. Where there are gaps, they can also make their budget to fill in those gaps. And that is where we are as it is today, but we will still need much more support to cover this missing link of distribution to the last mile. And so I would love to encourage more and more partners who are online from U4O to support us in the distribution to the last mile, as well as supporting private sectors or supporting small and medium scale industries to support them with finances and some other equipment that can assist in the distribution. Again, cylinders, which is what is really need to transport this oxygen to last mile. It's a bit of problem in Nigeria because the Nigerian government lumped it together with cooking gas and put a heavy tariff on it. So getting cylinders into the country is quite expensive. And thank you to my friend Jason. We have been up and doing and trying to see that this situation is reversed so that cylinders can become cheaper and it can also be made available so that the distribution can become more effective than what it is today. Thank you.
Thank you so much. That was Dr. Gilbert Shetak, a very important leader in oxygen, not just in Nigeria, but Nigeria is really a pathfinder country for many other countries. So where Nigeria goes, others follow. And we're very grateful for the leadership from Dr. Shetak and indeed the wonderful minister, Dr. Pate, and all of the team that work at the National Oxygen Desk. You're getting a lot of love there and applause. Dr. Shetak, thank you for being with us, and your call is very clear. Let's move now to our remaining speakers. We have a few more, very important. Sheila Bagayana from Oxygen CoLab in Uganda. Sheila, over to you.
Thanks, Liv. I would start by saying that Uganda is also one of those pilot countries that has shown great leadership in the oxygen space, starting with being one of the first countries really with a national oxygen roadmap and with the government investing in oxygen production. However, with that, from our recent private sector mapping exercise, we still found that over half of facilities still do not have a 24-hour availability of oxygen. And we're wondering, why is that, with the huge investments that are still happening or that have happened over the COVID period and beyond? Why is it that oxygen availability is still, oxygen is still not available, or when patients need it all the time? Next slide. Yes, as Jason was sharing about the missing middle, which are the pillars through which CoLab has been working to really find solutions and gaps to what we understand the problem as is. We have seen that currently production is really not the issue, and the issue is how do we ensure that this oxygen that is produced is actually reaching the patient? And in Uganda, we've really focused on two areas, mainly SME support and regulatory reforms. And for the first time in Uganda, we've done a mapping exercise to understand what's the demand, what's the supply within the private sector. What does that look like? What's the SME environment? And what do these SMEs actually need to thrive, to be able to bridge the gap between production and supply? Next slide. Yeah. So we've interacted with over 200 different stakeholders, but what is still clear is that production is not the issue. However, the issue is the fragmented market. So with over 45 different distributors, but still oxygen is not reaching the facilities where it needs to reach. And this is the missing middle that we are trying to address and trying to find solutions to, that we believe SMEs actually have a huge role to play in bridging this gap. Next slide. So in terms of production capacity, there is enough production in country, both from private and public sector. And what we're actually seeing is there is still a regulatory gap. And as we said, that how we are really seeing this work is that regulation is not just about compliance, but how can we use regulation as a tool to shape the market and ensure that there is growth of SMEs and the oxygen environment and the value chain is growing. So with that, we've engaged with National Drug Authority to just understand what are the different challenges with regulation. Why are 60% of the manufacturers, these were self-reported, not complying to NDA, and yet there is a huge need for this, to ensure that our patients have quality oxygen, but also ensure that we have a market that supports even the small SMEs to comply and provide quality oxygen. Next slide. Yeah. So we've seen disparities in the distribution or availability of oxygen, where there is an increase as you move far away from the central district, which is Kampala. You find that oxygen becomes more expensive and even harder to acquire as you move to the different areas. And we believe that with investment in SMEs, with improvement in the regulatory frameworks, SMEs can actually reliably distribute oxygen to the farthest communities that need the oxygen the most. Next slide. Yeah. So as I mentioned before, that from our mapping exercise, we discovered that 60% of manufacturers noted that they were operating without NDA certification. However, with clarification from NDA, it was actually less than 1%. And we have 91% of distributors also lacking a form of regulation. We have some distributors operating with even no licensing, and most of these production facilities were actually noting that they were doing GMP trainings. However, there was no formal GMP certificate owned or There were none of these facilities was actually GMP certified apart from a few. So what does this really tell us? Next slide. So what does this really tell us? So this tells us that there is a huge gap currently. However, there is a huge role for SMEs to play. And as the regulations are changing, as the policy environment is improving with the work that's currently ongoing, there is still a role for SMEs. And as partners, we have a role to support SMEs with investment, with creating frameworks and regulatory environments that support their growth so that they're able to meet the current demand that's in the facilities that they're serving. So with that, I would like to hand over to my colleague, Rachel Mujawimana from the National Drug Authority to take us through how NDA is working with regulations to ensure not just compliance, but market growth for some of these SMEs. Over to you, Rachel.
Thank you, Sheila. Hi, everyone. So just next slide, please. Just a little history about regulation of medical oxygen. Before COVID, NDA used to regulate mainly the importation of devices that fall under the regulation of oxygen, like concentrators and consumables. But in terms of regulating the manufacture, that was not done until the COVID-19 crisis. And what happened during this time is that mainly industrial oxygen suppliers were able to supply this need during COVID, and NDA was forced to ensure that what was on the market was regulated to ensure that pure oxygen was on the market. And so this meant that these manufacturers had to align with the guidelines for the manufacture of medical oxygen. There was resistance initially, even up to this date, but it's less with awareness. And of course, this just needed strong collaboration between us, the regulators, the industry, and health partners. There was no way of closing them because they filled a need at the time it was needed. Next slide, please. I'll talk about, mainly before I talk about the challenges, I'll talk about the support offered by NDA. It mainly really includes technical support. We give information to players that are interested in supporting the market in the supply or manufacture, distribution of medical oxygen. We do continue to carry out import verification for any raw materials they might need for this activity. We carry out good manufacturing practice inspections and also stakeholder awareness. However, despite the support, the challenges that the manufacturers face that we have noted is that they lack preventive maintenance plans, and therefore their plants break down, their PSA plants break down, and without them knowing what the cause was, and that causes like a what does it cause? A gap in the supply. Many lack a quality management system, no quality control, inappropriate cylinders, handling and storage issues, and generally lack of awareness about medical oxygen because they think industrial oxygen and medical oxygen are one and the same. And then in terms of regulatory challenges, we are in the process of revising and updating our GDP guidelines. We didn't have the storage part in it, but good practice, global good practice, necessitates us to have good distribution and storage practice guidelines, which we are in the process of working on. It's taking a while, but yeah. There's also the lack of awareness. Despite the work we have done, there's still lack of awareness of the requirements needed for medical oxygen. And I think Sheila just alluded to this in her previous talk. And therefore, there's need for more. We can't say there's enough awareness engagement. And so we have plans as resources allow, to engage the industrial oxygen manufacturers even more. Next slide, please. And so I would just like to conclude by saying that we need to strengthen our regulatory frameworks, as earlier mentioned, and also collaborate with industry, our innovators that fall under this category, and health partners to ensure that there's a supply of safe and quality medical oxygen. And ultimately, this leads to increased patient safety. Thank you so much.
Thank you, Rachel. We're going to invite Jason back to help us understand a little bit about what we've just heard.
Yeah, thanks, Leith. So I think what we're hearing across Nigeria and Uganda, we have two countries that have really been at the forefront of improving oxygen access for over a decade. The challenge is fundamentally shifting. So both countries now have very strong production bases. Both have very strong numbers of companies and partners sitting in the middle of the value chain, trying to bridge the gap between production and patient access. Those companies are that missing middle, but they need help reaching their full potential. And we've heard from officials in both countries on what their governments are doing to try and facilitate bridging that gap between production and patient access. Stronger procurement, clearer regulatory pathways, more sustainable financing. We're also hearing what they need from our community to do it well. And so the question, I think, for everyone on this call is, how do we support that with the right kind of finance, the right kind of technical partnership, and the right patience, so that what gets built actually lasts and delivers patient access in the future. We'd love to hear your reactions, your questions, and your feedback. So I think, Leif, I'll actually maybe pass it back to you to open up the Q&A portion.
Great, thank you, Jason. I want to thank our second session speakers, Jason, Dr. Shetak, Sheila, Rachel, for those presentations. And now we have a nice amount of time to just dig into this a little bit. We've got a couple of questions in the chat. I'm going to ask Jason to continue engaging with Lisa on that technical issue about oxygen purity. And perhaps we want to kick off with Amapreet's question in the chat. Amapreet, please come on and feel free to voice that, and we'll give you the first question.
Thank you, and thanks everybody for the presentations. It was really helpful. So just a little bit of context, we are the suppliers of the Pulmo 2, which is the world's first fit-for-purpose oxygen concentrator, which CoLab had a part in catalyzing, as well as I think a number of the other members in this call today. Obviously, it wasn't just enthusiasm and a care for doing good in the world for why we developed a product. We are not a nonprofit, so there has to be a sustainable marketplace that exists. But the hope was that as the evidence comes in, as there's somewhat of a growing acceptance that the current oxygen concentrators are not fit for purpose and are failing, we were hopeful that there would be success in adoption across various countries for the Pulmo 2. And my question is a little bit around how do we improve the Pulmo 2 or other fit for purpose technologies along with Oxygen as a Service program so that they are able to actually operate at scale in a country. So, for example, in Nigeria, we've tried to engage with, I think, all of the things that were mentioned on this call. We were present at some local conferences. We met with various groups from the government side that were designed to help improve these things. We actually worked with a local Oxygen as a Service provider to try to make some Pulmo 2s available in country at a reduced cost to get some traction and get going. We've tried to engage with the Oxygen for All group, but we've not had any traction. So I would love to hear from the people on this call. Uganda may be somewhat similar, but slightly different, where there's a bit more of a government engagement to improving the equipment that they're using and work with Oxygen as a Service programs. So keen to understand, obviously it's more expensive, right? I don't think it's a lack of will of why we're not seeing traction, whether it's a oxygen as a service program or fit for purpose equipment being adopted. But really keen to know what further we can do or what the people on this call who've presented can maybe recommend or suggest so that we can take these things from maybe ideas and turn them, or initial pilots, and turn them into scalable within AOPs, within budgets, programs that are effectively operating across the country.
Okay, so I want to zoom out a little bit on this question. This is a question about company to government relationships. So if we're talking about the missing middle, most of the organizations in it are private sector that provide those services. But as we all know, historically, company to government relationships in health, company to global health and NGO relationships in health are fraught with issues. So if we're going to take advantage of this new model, we're going to have to create ways for companies to engage directly with governments and other partners. So who'd like to give us, maybe someone's got a very good model here or some examples for that work for both sides. This would be your opportunity to share them. We're also happy to have some of our speakers respond to this issue if they'd like to.
So, Leith, I can maybe come in
Please do.
and speak a little bit about this. So, I think without stealing Dr. Shatak's thunder, he mentioned the U4O group in Nigeria. And that group actually does include a handful of more private sector oriented groups and private sector companies. I think, and Dr. Shatak, you can correct me if I'm wrong about this, but they're welcome to participate in that U4O forum. I think sometimes it's a little bit of a different kind of interaction than private companies are looking at. The challenge, not just in medical oxygen or medical gases, but in like medical products generally, is many, especially like state governments, are very reticent to allow private companies to come in and be a part of like their annual operational plan processes, et cetera. I think in the pharmaceutical landscape, what you see is that classic model of detailing where you have, as a company, either your own structure or a local distributor, a local company on the ground who goes directly to health facilities and clinicians and gains adoption of a product or a service, right? And Aisha can speak, I think, and at much more volume than I can about HealthPort's model, and indeed the way that HealthPort goes direct to health facilities to sign them up and contract as a part of their customer acquisition strategy, but also engages with state governments, usually through, for instance, like the Hospital Management Board or potentially a Ministry of Health. So I think one of the key things across countries is it's very, very hard sitting as like a multinational company and engaging with global like NGOs, et cetera, getting traction down to the levels of local procurement where medical oxygen is purchased. A lot of the models we have at the global level for facilitating private sector engagement are based around centralized donor-funded procurement models via, Gavi, PEPFAR, Global Fund. And for a lot of essential medicines, which medical oxygen falls under that category, the procurement really is happening at a local level with local resources, and it's a completely different set of processes. So companies who do that well are the ones that are going to have those local partnerships. And I do think this is an area where many of the medical oxygen partners on the NGO and nonprofit side can do better bringing private sector engagement into their scope of work and helping to bring private companies to the table. So we're hoping to see more of that as a follow-on to some of the supplier mapping and landscaping exercises that have happened in Uganda and Nigeria by setting up forums in country for private sector companies to interface with decision makers, but in a way that the decision makers and policymakers on the government side are comfortable with, and doesn't make them feel as though they're kind of letting private sector companies in to influence what they're actually structuring their budgets behind. And then those same companies potentially bidding on tenders, et cetera. But I do think that part of the answer, if you're a private company looking for a way in, is choosing the right local distributor and servicing partners on the ground who can go direct to facility and then also engage with state governments. And part of the answer is partners in the space really changing how they're operating to help government create structures for private sector companies to engage meaningfully, but with the right firewalls, so that we don't get kind of perverse incentives happening on the procurement side.
Thanks, Jason. Amapreet, maybe we can triage the Oxygen Nigeria issue here. So United for Oxygen is the name of the coalition, U4O, United for Oxygen. You can see Eno Edems on the call here. She works directly for Dr. Shetak. Why don't you just, we connect you two and you can talk to Eno about if you've already requested to join that group and you haven't, maybe you didn't get a response, we can fix that after the call so at least they engage with you.
That'd be great. And I would love, I think Jason's got some good ideas. I think Jason knows who our partners on the ground in Nigeria are. So it's good feedback, certainly.
Okay, thanks for that. Thanks for raising. We have a question from Cami Lee. Fantastic, Cami. Cami, do you want to come on and voice that over?
Sure. Hi, everyone. Great presentations all, and really wonderful to see the progress here. I was curious just to hear a little bit more about the financing issue. These SMEs seem to me a little bit like a corollary for like sort of the pharmaceutical value chain. And I'm curious, when I think of the pharmaceutical value chain and kind of the role of distributors and wholesalers and that, and I'm curious if the funding issue is more around the lack of public sector funding, like at the county level or at the state level, at LGA level, to contract with these SMEs, or is it more about the SMEs having access to working capital to really be a viable business to, at a setup and sort of operating cost range? Because there's a lot of CapEx involved, I imagine, in getting these set up. Thanks.
Great. Who wants to take that one on?
I'm happy to start, and then maybe we can hear from our colleagues in Health Board and Frio 2 and perhaps Dr. Shitak. But I think it's both, Cami. I think it's both. It does speak to both, our mapping and our understanding is that it's not that funding doesn't exist in the system, but rather that it's fragmented across different parts of the system. So yes, we think there is a need to create dedicated oxygen budget lines, and we've seen again from Nigeria and Uganda incredible progress towards that, and really building and having investment cases on oxygen, and at the same time, as you rightly pointed it out, there is a need for working capital and de-risking the entries to market of these SMEs. CapEx is for sure an issue for them to enter the market, and also to build the right track records for these governments to actually be able to contract them, right, and for them to be able to respond to RFPs from ministries of health. So yes, we see it as both of those different issues, but I wonder if my colleagues would like to add more nuance.
We can take one more on this, if somebody would like to come in.
Can I volunteer Aisha maybe to speak about this from Health Board's perspective? I know she's got some good thoughts on what the catch-22 is between accessing financing as an SME in the absence of structured guaranteed demand.
Great, Aisha. Aisha, can you come back? She may have stepped away, Jason. Do you mind saying what she would say if you know?
I will do my best, Aisha, impersonation. And I was just talking to her about this yesterday, but Healthport is at a scale where they're looking for the type of investment that we would normally talk about as like VC funding. The problem is that they're getting a lot of people coming to her who understand the fact that health facilities have trouble paying. They have trouble paying on time. They have trouble paying in full. And so when the health facility is your main customer, you run into a situation where your funders want you to already have scale so that your payment risk is diversified. And they look at it as a safer investment as a result. But to get that scale, you need the capital. And so that's where I think to your question, Cami, there's plenty of money oftentimes in these systems to pay for oxygen, but some of it's at the health facility level, some of it's with the hospital management board, some of it's with the drugs management agency. And it's not brought together, and it's usually like cash and carry, right? Where they're purchasing as they need. So what a company like Healthport would need to get access to the right type of capital is basically some form of a contracting mechanism that allows them to say, this entity, whether it's government or someone else, has committed to purchasing this much from me, or I've got a contract to supply 30 health facilities. And we're going to then be able to bring that as evidence to a funder to get the capital. So it's not just a matter of, is there enough money in this part of the system to purchase, or is there enough access to capital? It's often the connection between the financing for the demand and the capital for the investments. And the problem can sometimes be not that neither is there, but that the way each is structured, you can't connect them properly. And so a business kind of has to struggle through a very difficult valley of death in order to make it out on the other side and have the scale to be able to mobilize investment that would let them grow quickly. So there's also those interplays where it's not just about, is the money available on either side of the equation? It's about how is it structured and can they connect?
Thank you, Jason. So we're going to pivot now to our final 10 minutes. But if you have other questions, please put them in the chat, and we save the chat and the team will respond to you. But let me just come on video. I just want to do a little handover. But before I do that, I just want to say something about the CoLab. The Oxygen CoLab is a very small group, and they are relatively new players on the scene to medical oxygen, to global health. And in a short space of time, this small team has produced this body of work. You've had a taste of it today, and it's an extraordinary body of work. It's not only quality work, but it's really changed the way we need to think about increasing access to medical oxygen and everything that goes with it. So this small team has really had seismic impact, but it's up to us now, the rest of us, including the very large organizations, UN, multilateral agencies that work in oxygen, to pay close attention to these results and to really be open to changing the way they do their business. But I just want to congratulate this team. They've worked so hard. They've overcome so many barriers. They've built such a strong network, and they deserve to be applauded for that. The oxygen field is better off, much, for the fact that they took this on and pushed it so hard. So Alex, over to you as director of this extraordinary effort to take us out.
Thank you so much, Leith. It really means a lot to hear that from you. We had almost 90 minutes together today, and as Leith said, we got the chance to hear from different voices, from entrepreneurs, from government champions, from the researchers measuring the impact of this, and we wanted to take the moment at the end of the session to really pull it all together and think and see what this all adds up to. You've heard Dr. Shitak. We have the production. I think he said, we're almost saturated with oxygen system, but having the oxygen isn't enough. How do we get it to the bedside is the next era, the next question. And we also heard about Amarpreet talking about how difficult it is to get traction even when fit-for-purpose devices exist. So the bottom line there is indeed the production is there, patients still don't have access. At the same time, we also heard today from Karina, who led the independent evaluation, that showed that when you outsource oxygen services, equipment is indeed dramatically more functional. It is more available, more appropriate for patient needs. 95% of the time functional versus 25% when there's no service-based models. So we are seeing this as many of the speakers have been making this point throughout this session today. We are seeing this as the missing piece today, and as Leith rightly concluded at the end, we are also seeing this as the key opportunity for the future. And we do believe that for this to happen, indeed, you've heard from Jason and his part of the session. We really need to build the markets that will take this forward. We did we did a lot, and we had a lot of focus on evidence, but we know that this evidence is not sufficient if what stands in the way are regulatory barriers that we heard from both Uganda and Nigeria, pioneering governments when it comes to oxygen. There is a need, both of them saying, for regulation for fit for purpose. We heard about the supply inequity and how facilities pay so much more per cylinder than the capital. We heard about the procurement reform and so much work to be done to give government comfort about doing business with private sector companies and so on. And these challenges really, we believe, require deliberate, targeted investment, and they require this investment in the market conditions that really will let these businesses operate and scale. And so it happens that we're doing this in 2026. We started by talking about this shift from aid to investment. I think Leith concluded really well. It is the moment to to move forward. This is no longer a panel talking point. It really is the reality that we all operate in. And so, yeah, we really hope that today has shown all of us that medical oxygen is not caught up in that transition of the shift from aid to investment, is really ahead of it. And what's been proving here could really become a blueprint for how the sector navigates this shift, and how every single essential service that fails because the ecosystem around the equipment was never built. So thank you again, Leith, for the opportunity you offered us to share this work. In closing, I'm going to be direct. We are in fundraising mode. This is the end of the FCDO funded phase of these 5 years together, but it's definitely not the end of the work. The businesses you've heard from today are not closing. The government reform efforts are not stopping. And what we really see right now is that there is a need for a next generation of investment to really take this forward. And yeah, you might have seen online, we've been calling our campaign Fund What Lasts, that this webinar is also part of, and that's because that's all what this all adds up to. So if you're a person who wants to do this work with us, or know anyone who would like to keep going with us, we definitely would like to meet them. Thank you.
Thanks, everyone. Enjoy your week. Look at all that wonderful information in the chat. Please be sure to follow up. The recording will be available today on YouTube, and I'm sure the CoLab will send it out on their sites. So if we had 101 people on this call at the top of the hour. If you have people in your network who need to see this, you'll be able to share the recording. But bravo, everyone, and thanks for joining us. Bye-bye.
Thank you.
Thank you.